So let's carry on with our revision. So center score, we look at center score for streptococcal pharyngitis. Essentially, it's it should be used in patients with recent onset acute pharyngitis, so 3 days or less onset of something with acute pharyngitis. The basic essence of the center score, or when the fever pain score, is to predict the likelihood that the patient who has a sore throat could have a streptococcal pharyngitis, essentially bacterial pharyngitis, because most pharyngitis are viral. The question that you need to be looking at is the age. If you look here, you say age strep is right under 3 years of age. So if a mom who is with her child who's 2 years of age, of course, with upper respiratory tract infection kind of symptoms, child is complaining of sore throat, has runny nose, painful swallowing, the temperature as well. For instance, now you're thinking one of the things that might be reassuring with lack of gestures is rare under the age of 3, but it's not uncommon. It's not impossible, rather. We don't use that as an excluding factor anyway, but just for you to be able to say, okay, that is actually quite rare under the age of 3 years. Obviously, you need to look at a holistic picture. So the child is 3 to individual is 3 to 14 years old, score plus 1 on the center score, which means you have a lower threshold of prescribing antibiotics in children, if you have a look, than than adults. There's exudate or swelling on the tonsils. So exudate, swelling on the tonsils. Swelling on tonsils alone +1, which means the tonsils are enlarged +1. There's exudate on the tonsils, still +1. If you have tender, swollen anterior cervical lymph nodes, +1 on center score, and a temperature of more than 38 degrees Celsius. So how do you apply these in the SC? The most important thing is to know that, okay, these are the questions you should be looking at stuff. So temperature, fever more than 48 degrees. If cough is present, when it's unlikely, it's less likely to be streptococcal pharyngitis. If there's absence of cough, then it's more likely. I usually prefer the fever pain anyway. The fever pain, fever in the last 24 hours, if yes, absence of cough, +1 symptom onset, less than or equal to 3 days less. Prevalent tonsils, which are the exudates, +1, severe tonsillar inflammation, the tonsillar swelling. That's here just put together. It's more about knowing the questions that make the streptococcal pharyngitis more likely, and then you need to present those facts or those information before the patient and say, okay, because of these, I suspect you might have a bacterial infection in your throat. I think you very likely benefit from a course of antibiotics. What do you think about that? Always check what do you think about that. It shows you're not just doing things, on your own, carrying the patient along. These patients, it shows you're recognizing patients' autonomy. The patient can say, well, no, doctor, you know what? I don't want antibiotics. I'd rather just probably carry on salt water gargles, just use some strepsils, take some paracetamol. Maybe I should give it a few days and see how things go. Patient autonomy has to be recognized and respected. Pediatric traffic light system assessment of an unwell child. So let's have a look. So of course, normal color, so the green means normal color response normally to social cues. Child is content, child smiles, stays awake or awakens quickly, strong normal crying, or not crying. And the child looks settled, normal skin and eyes, moist mucous membranes, none of the amber or red symptoms. So generally, when the child comes into your consulting room, the first thing you want to look at is how the child looks. The child crawling happily, the child looking at you, smiling, alert. The child, pulling, reaching out for your stethoscope, reaching out for your eyeglasses. You know what I mean? Child really active. The child jumping, climbing your couch, examination, or trying to jump onto your examination. So child is active. It gives you the first impression that this child very likely is not, unwell in a life-threatening way. So let's look at the amber or intermediate risk. So pallor reported by parents or reported. So you say, oh, my son looked pale, you know, he looks pale. So not responding normally to social cues, no smile, child looks grumpy, wakes only with prolonged stimulation, decreased activity. So child is really looking lethargic, not really playful, not smiling, looks tired, just looks laid back, and you know, there's nasal flaring, the child is tachypnic. And tachypnic means respiratory rate of more than 50. The child is of age 6 to 12 months for an infant, or age respiratory is more than 40 breaths. The child is above a year. Oxygen saturation, so oxygen saturation 95% or less. Crackles to the chest. That's like okay. So amber signs. If the child is tachycardic, his heart rate is more than 160, the child is an infant, or more than 150, the child is aged 12 to 24 months, or more greater than 140, the child is above 2 years of age, 2 years and above. Capillary fill time prolonged, so 3 seconds or more. Try mucous membrane, poor feeding in infants, reduce urine output. These are amber signs. So it's good to know the amber signs and the rest. A lot of children, usually, of course, most children will develop amber signs first. And if left unchecked or unrecognized or ignored, then obviously they could progress to the red signs, actually more life-threatening. So for see on the amber, the child is of age 3 to 6 months, has a temperature of 39 or more, fever that's lasted for 5 days or more, because like in that case, you think it could have Kawasaki syndrome, Kawasaki disease, which could cause like coronary aneurysms. We don't want that. So presence of rigors, if a child is shivering, it's not really common to see children like shivering. If a child is really, really having like rigors, tells you that okay, very likely temperature is very high. Swelling, swelling of a limb or joints, non-weight bearing limb, not using an extremity. So non-weight bearing limb, so you thinking about this child actually have um, sustain the fracture, or if there was osteomyelitis, there's cellulitis or something going on in that limb, painful limb, you know. So red or high risk, the child is pale skin, mottled, ashen, blue, so I know there's no response to social cues, appears ill to a healthcare professional. So you can see that the child looks vibrant to you. Tells you that, oh, very likely whatever is going on will just be a viral infection that's probably recovering already or resolving. Child looks so dreadful, so lethargic, just looks everything. The child just looks like they're gonna fall asleep and probably never wake up again. Like, you get that sense of this child just looks dreadful. The child is just breathing with so much difficulty, retracting all the intercostal, muscles, subcostal retraction. The child looks like someone that is probably gonna take their last breath if nothing is done within the next hour. Child looks ill to you as a doctor, you should be, that's a red flag. The child does not wake or is not aroused, or if roused, does not stay awake. So the child is probably just sleeping, you're stimulating the child and child just not waking up. Weak, high-pitched continuous cry, the child is grunting, the child is tachypnic, so heart rate, respiratory rate greater than 60, and age, so respiratory rate of 60. Onset of severe chest drumming, the chest drumming, only as retractions, intercostal subcostal retractions, even use of other respiratory, most of the accessory muscles of respiration, using your skin, mastoid, and trapezius. The child is really struggling to breathe. Reduced skin toggle. The reduced skin toggle is red, but when you have reduced skin toggle, tells you that there's actually significant, very significant dehydration of the skin. The dehydration has got to the point that it's now manifesting on the skin. Because first of all, dehydration will leave the circulation first. That's why you have the circulatory aspects. Once you now get to the skin and you tug the skin and it's just taking time to lost that elastic recall. You're thinking, oh yeah, red. A child who is less than 3 months old, temperature of 38 or more, red flag. Non-blanching rash, non-blanching rash, or thinking of meningococcal meningitis, very that's a red flag. Bulging fontanelle, thinking of meningitis is raised intracranial pressure. Next, stiffness, status epilepticus, which is seizureless, lasting more than 30 minutes. Typically, so if you don't want the seizure to last more than 5 minutes, usually advise parents with a child having a seizure lasting about 5 minutes before they are mounting looking to status epilepticus means more than 30 minutes, high risk of brain cerebral ischemic encephalopathy, anoxic injury of the brain. Focal neurological signs, thinking of space occupying lesion in the brain, could be a cerebral abscess from meningitis, or it could be a brain tumor, or bleed if the child has sustained a head injury. Focal seizures. So focal seizures are red flags. You're happier when you get generalized seizures in a child. You have focal seizure, you're thinking of, cerebral abscess, brain tumors, and things like that. So something that's quite common in primary care as well is bronchiolitis, which can be confused with a bacterial chest infection or can be confused with an acute exacerbation of asthma. Because typically the child bronchiolitis presents like a mixture of pneumonia and asthma. The child is probably very likely going to be febrile, febrile, people have a cough, they are thinking a chest infection, which could be undifferentiated as the bacterial versus viral, but then the child could very likely be wheezing as well, which is an asthmatic and airway limitation, symptom, airway constriction symptoms. So you're thinking this child have a viral induced wheeze, which obviously that's what it would be, isn't it? It's a viral induced wheeze. You're thinking could there be a possibility of asthma as well, undiagnosed asthma at that early age. So you're thinking, something fine. Could be bronchiolitis. A very common thing to do is to give them or call it delayed antibiotic scripts. So if the child carries on being unwell, obviously there can be bacterial super infection, superimposed bacterial infection. So you give them a delayed script. So if the child continuing carries on having temperatures, or really having this bad cough, you could actually commence the antibiotic. So bronchiolitis is something that is quite difficult to diagnose in primary care or even by the pediatricians. So the child is less than 12 months presents. So this is actually ED presentation. Just for us to see things that are commonly done. The question is, does the child have toxic features? If yes, managers sepsis. The toxic features would be temperature of 38, yeah, low blood pressure, so hypertension, tachycardia, someone that's having a heart rate is greater than 60, 150, 160 depending on age, and respiratory rate. So I think, okay, yeah, very likely toxic features. So you have to initiate the sepsis protocol, which is essentially intravenous antibiotics at that stage. The child is so unwell. If there are no toxic symptoms or septic symptoms, consider differentials or dual diagnosis. Exactly. So if you have dual diagnosis, the child could have a bacterial chest infection. So well as having a viral injury. So you don't, there could be a mixed picture, and that's something we should always bear in mind. Age less than 3 months old, if yes, managers per fever guideline for infants with temperature of 38 or more. Age less than 28, so a neonate. If the child is older than 3 months, then bronchiolitis diagnosis, assess severity. So you can see the child is less than 3 months old. You don't rush into making bronchiolitis because you know that that child is at high risk of mortality if there's actually an ongoing severe bacterial infection in that chest. You need to have a very low threshold for initiating antibiotics in a child less than 3 months who's having temperature of 38 degrees or more. Because bronchiolitis is viral, usually results on its own supportive treatments. But if it's bacterial at that age, the child is so vulnerable. You probably wouldn't lose much if you start antibiotics as quickly as possible. Like we're thinking bronchiolitis, assess severity, mild, moderate, or severe. If it's a mild bronchiolitis, we can give small frequent feeds. Consider nasal saline drops prior to feeding, just to clear the nostrils and improve breathing because the breathing is blocked, the nose is blocked, the child tries to feed. Because they're breathing through their mouth breathing, and they'll become more breathless when they're feeding. Is the child responding to treatment? If yes, identify risk factors for severe disease, gestational age less than 37 weeks, prematurity, chronological age less than 10 weeks, chronic lung disease, and if the child has a cystic fibrosis, things like that, or asthma, congenital heart disease, chronic neurological conditions, indigenous ethnicity, failure to thrive, trisomy 21, postnatal, exposure to cigarette smoke, breastfed for less than 2 months. With moderate bronchiolitis, moderate symptoms, nasal saline drops. So nasal saline drops are very important. Plus or minus suctioning, you need to clear the airway. Oxygen plus HFNC, high flow nasal catheterizing, in high flow nasal catheter for oxygen to maintain SpO2 of 92 or more. Consider fluids via NG tube. If intake is less than 50% for 12 hours. Responding to treatment, if yes, consider referral to inpatient service. If no, then you make a diagnosis of severe bronchiolitis. High flow nasal catheter oxygen, maintain oxygen 92% or more, fluids via NG tube and intravenous fluids. If responding to treatment, refer to inpatient service. Why? Responding to treatment, refer to inpatient for if not responding to treatment, fluids IV, blah 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 blah. This is A&E actually. This is A&E management. If responding, they admit under PEDS. If not responding, obviously, you will be, the child will be in resource, the child should be in resource, obviously at this stage. But this, a lot of this should happen in resuscitation part of ED. Consider, of course, blood culture, blood counts, renal function, BBG, IV antibiotics, checks are sure you want to make sure I low threshold for intubation, just to avoid respiration collapse and cardiac arrest. If responding to treatment, yes, refer to PEDS for observational treatment and ward. Not responding, refer to pediatric critical care childhood. And likely going to pediatric ICU, respiratory and cardiovascular support. The less common causes of respiratory distress in infants. Bacterial pneumonia is less common in infants. Bacterial pneumonia, including pertussis, aspiration of milk, tracheal bronchomalacia, cystic fibrosis, congestive cardiac failure, sepsis, intrathoracic mass, ejection. So they are less common, but they are possible. So you need to consider concurrent or alternative diagnosis of serious bacterial infection or illness in children with high fever. Always think about that. Children can decompensate so rapidly. Alerts. Consider cardiac disease in infants with the following: no precipitating viral illness, hypoxia, out of proportion to severity of respiratory disease, plus or minus abnormal or unequal peripheral pulses, cardiac murmur, hypotension. Keep in mind the compensation can be treated by intercurrent illness. It's always good to think cardiac as well. The child is having a chest symptom, having a wheeze. Don't just think it's viral induced wheeze. Ask yourself, could this child actually be developing heart failure from a congenital heart problem? The bronchiolitis diagnosis requires a history of an upper respiratory tract infection followed by onset of respiratory distress with fever. So there has to be fever, there's respiratory symptoms, then presence of one or withholding cough, tachypnea, retractions, diffuse calculus or wheezing escalation. So of course, presence of, I kind of looked at the pediatric tract, particular presence of retractions, clearance sign, it needs to be as a fairly threshold for admission or you to speak to PEDS. But diffuse crackles or wheeze, because from my experience, a lot of children who have bronchiolitis coming looking very well. They're retracting, they're breathing fast, really noisy breathing, stridorous breathing, or wheezing. They just look dreadful. In that stage, most times we admit them to PEDS. PEDS typically would do a blood culture, VBG, and eventually chest X-ray. Chest X-ray will just show, haziness, generalized haziness, no focal consolidation belong. VBG, could show, or VBG show now respiratory alkalosis, isn't it? In child hyperventilating. So assessment of severity of bronchiolitis. So behavior, normal. So mild, normal behavior, mild tachypnea, nail to mouth, chest wall, and retractions. If you're having retractions, marked chest retractions, it's severe, marked tracheal tug, marked nasal flaring. So this tracheal tug is not something I've really particularly paying attention to. I'm being honest now, but it's something I need to start thinking about more. Tracheal tug, nasal flare here, if it's obvious, but you need to actually look. Sometimes you need to look closely to see, look at the air and the side, see if they're flaring or not. So nasal flare is also moderate. Tracheal tug. The brachial tug is like when you look at it, when you look there, it's pushing in, like it's collapsing. When the trachea is collapsing, you've seen the child breathing with difficulty. Imagine trying to suck water, trying to suck water through a pipe that is blocked. So what happens is that because of the vacuum, because there's a blockage somewhere, when you suck, you create a vacuum, and that tube, that straw, that pipe collapses. So that's what happens in tracheal tug. So you notice that indrawing, like a retraction, it's like a tracheal retraction. Oxygen saturation more than 90%. You're thinking mild, it's less than 90, may not be corrected by oxygen. So it's very, very, have a very low threshold actually. Apneic episodes, but the most important, even if it's thinking mild, if you're thinking moderate, speak with PEDS. Don't send one. If you're thinking mild bronchiolitis, what I typically look out for is respiratory, is oxygen saturation, presence of retraction, subcostal, intercostal retraction, renal nasal flare, and things like that. And of course, feeding. The child is not feeding, and writing nappies, and thinking circulatory collapse is bending as well. So one of the things I typically look out for, but other things are here, start looking out actively for tracheal tug again. Increasing irritability and lethargy or fatigue. So it's really a red flag. It's high risk of respiratory or cardiovascular and circulatory collapse. Still on bronchiolitis, lower respiratory tract infection management. Essentially, it's just supportive management with fluids, ensuring fluids that orally or intravenously have to check plus or minus. So usually no antibiotic, you think is clear cut bronchiolitis. You're thinking there's a superimposed bacterial infection with fat antibiotic, but typically not. Use of bronchodilators is controversial. Most times bronchodilators are not used, but if the child is really wheezy, and you might need to consider some aerosolized salbutamol, maybe nebulizer. Maybe use a short course to open up the airway. But most importantly is to use saline nasal drops, to clear the upper airway, the lungs, the nasal passages. So referral criteria for tonsillectomy. Okay, so someone that's having frequent also referral criteria for tonsillectomy will only be routinely commissioned in adults and children in Devon, because that's what I'm training. In the following circumstances: peritonsil abscess of Princey. If you're suspecting peritonsil abscess, then you need to know the tonsillar enlargement causing or contributing to acute upper air obstruction. So previously, a child is struggling, having obstructive sleep apnea, or both obstructive sleep apnea, obstructive daytime apnea, difficult, struggling to breathe, really stridorous. You might need to remove one of those tonsils, partially or completely. Recurrent acute sore throat due to tonsillitis with the following criteria. So recurrent acute sore throat due to tonsillitis. The documented evidence of 7 or more episodes of tonsillitis in the last year. Within the last 12 months, they've had 7 or more tonsillitis. They've had 5 or more episodes within the last 24 months. It's usually good to look at it in terms of months. Because when you see this person in June, for instance, or September, so you're looking at it within the last 12 months, because 7 or more, within the last 24 months, you've had 5 or more, within the last 36 months, you've had 3 or more of such episodes. Okay, per year. Yeah, so if it's over the last 36 months, so if they've had 9, you know what I mean? So if you've had 9, for instance, in 3 years, just average of 3 or more a year. And there has been significant impact on quality of life. So it's not just having tonsillitis. If they have mouth tonsillitis, it still doesn't count for, tonsillectomy. If they had tonsillitis that had significant impact on the quality of life, they're unwell, with indicated by documented evidence of symptoms that act as a barrier to employment or education to the child being off sick, off school, for instance, because they were so unwell or carrying out care activities, so being off work or being off sick, with those episodes of tonsillitis, then you need to say, oh, this person is really having significant burden from the disease, we should be moving it. If there's a failure to thrive in a child with tonsillitis, then we need to consider removing tonsils. In line with NHS guidance, for 18 after appropriate specialist assessment, tonsillectomy may be considered at a lower threshold than the above for the following indications. There's acute and chronic renal disease resulting from acute bacterial tonsillitis. So the child has post-cerebral glomerulonephritis, which may have progressed to the CKD or whatever. So acute and chronic, either of them, it needs to be considering tonsillectomy. As part of treatment of severe gutted psoriasis, so the person's having gutted psoriasis from streptococcal pharyngitis, it needs to be doing tonsillectomy. Child, especially adults, developing metabolic disorders where periods of reduced oral intake will be dangerous to health. So, PFAPA, periodic fever, after stomatitis, pharyngitis, cervical adenitis. Assessment to include pediatricians, so the child having periodic fever, after stomatitis, pharyngitis, cervical adenitis. I haven't heard about this PFAPA before. Okay, so if the child has severe immune deficiency, that will make episodes of recurrent tonsillitis dangerous and needs to be referred for consideration of tonsillectomy. Now, tonsillectomy or adenotonsillectomy will find in children under 16 where obstruction of the airway resulting in shorter sleep apnea and the following apply a significant impact on development, behavior, and or quality of life demonstrated by supporting evidence such as growth charts, letters from GPs, or a strong clinical history, plus among sleep studies, so sleep studies. I also remember the patient I saw, the young chap, a teenager, slim chap, from the show from tonsil of sleep apnea, having symptoms really suggestive of obstructive sleep apnea or slim, so it just made me feel like, okay, a person who is of normal body BMI, typically when we think of obstructive sleep apnea, we think of people that have, lots of fatty tissue around the neck and airway, but people with completely normal BMI can still have obstructive sleep apnea. It's all about the breathing, the pharyngeal apparatus, so the muscles around the larynx. Muscles of the larynx are weak and flabby, and so when the person sleeps, then the airway is narrowed. That's what we're having sleep apnea. The tonsillectomy is not routinely commissioned, therefore, solely for the management of snoring. Because people snore, so the fact that snoring alone, you're snoring and having symptoms, the apneic episodes, and obviously having fatigue, daytime fatigue, which puts you at risk of danger. Obviously, we should do tonsillectomy. As person is not routinely commissioned for treatment of tonsil stones. Head and neck cancer services are commissioned by NHS as part of specialist cancer services. Treatment of malignancy, therefore, out of scope of this policy. And we're thinking of a tonsil malignancy, should you need to be with urgent referral to head and neck. So if we look at this anaphylaxis treatment before hospital transfer, should we do that? Maybe we should continue from there.